Now, the next concept was, of course, that these mutations does not occur randomly, but in a very specific category of the genes, and perhaps can help us to not only genetically and genetically classify the ML, but also for some sort of functional classification ML. In fact, it's recognized at least 7 different categories of a gene that are frequently mutated in this disease. And again, all these things has been done thanks to the application of NSG. So the WHO classification has been revised in 2016, and I would say an important, if not the most important component of these classifications, once again, is the identification of genetic abnormalities. Particularly, there are some categories that that cannot get away without really having an adequate molecular assessment. The leading, I would say, the leading category in WHO classification for ML is the one with the recurrent genetic abnormalities, and the new one of the myeloid neoplasm with germline mutations, particularly based on the presence of germline mutations in certain genes. They divide these in the one that are present without really any evidence of disorders, or the one that can be, that are associated with the pre-existing or before the AML developed, that have been associated with thrombocytopenia, the one that are associated with other organ dysfunction or other structural defect. And again, in 2017, a new version of the ELN has been published, and once again, molecular analysis has been a big part. In fact, you see here at the bottom, especially for adverse group, there have been at least 3 new subset of patients, or I would say subset of AML, or subtype AML that has been added, the one with RANKS mutations, the ASXL1 mutations, and the TP53 mutation that were not present in the previous classification in 2010. But the problem, the biggest problem, and the one that has been amplified by next generation sequencing, is the fact that we know that these mutations are not, although frequent, are not mutually exclusive, and not mutually exclusive either with specific cytogenetic abnormalities. And this is a very busy slide that has been published by ELN, try to summarize the different cytogenetic subset, how they are associated with the different type of gene mutations, and how the different type gene mutations associated by themselves, among themselves. And this is, again, going back to the TCGA paper in 2013. It was very evident that not only the mutation are not mutually exclusive with certain type of, are not mutually exclusive, but also they are associated with a very specific gene or microRNAs or DNA methylation pattern, making this even more complicated at the point that each patient may have his own disease, a biologic type disease, if all the information are taken into consideration. So I will envision, I will say that probably the modern approach to ML patients is to capture the genetic heterogeneity, having a bone marrow definitely send for a bioinformatic analysis, having a genomic bioinformatic biostatistician work on the data set, come out with some definition of biologic subtype for that particular patients. An ML tumor board may need to prioritize, adjudicate, and prioritize the lesions and adjudicate the treatment. And I would say one approach, at least for newly diagnosed, will be probably to have a backbone of chemotherapy or hypomethylating agents, combined eventually with FDA-approved drug or investigational drug based on the biological subtype that has been identified by integrating all the information that you can get from gene mutation, gene expression, microRNAs, DNA methylation, and so on. To date, we are far from that. There is only very few lesions that are being prioritized in terms of treatment adjudication. Of course, the core binding factor with chemotherapy, with the high-dose RAC-based chemotherapy plus or minus TKI, FLT3 mutations, midostaurin has just been approved to be used in combination with the chemotherapy. Probably will come for a newly diagnosed patient with IDH1, IDH2 mutations, the AG120, AG221, recently approved for a patient with a relapsed disease. And of course, there are some mutation that can be only used for, will be used just to stratify to chemotherapy. We don't have a molecular targeting for that. One more, and try to finish up, one more area where NSG can be used is minimal residual disease. We know that there is a lot of controversy, but it's very, very useful, the use of flow cytometry versus molecular. But when you come to molecular, you need to take care, especially with the increased sensitivity of NSG. You need to be aware of this CHIP, the clonal hematopoiesis indeterminate potential, and this mutation that can be present both in healthy patients, in healthy individuals, and in AML patients. So by the time that you finish with the initial treatment, the patients are in remission. You do a molecular analysis. If you have a DNA methyltransferase 3A mutations, is this part of the CHIP or is part of resistant disease? And this is the type of things that we need to sort out. Of course, in a relapse, it's very important to do in next-generation sequencing, NGS, both in a diagnosis, a relapse, to assess the clonal evolution of the disease and eventually change treatment strategies. So I want to conclude to say that it's a very exciting time, I would say, at least for ML. Just in the last few months, at least 3 different drugs have been approved for AML. We are really going very fast toward the implementation of a personalized therapeutic approach for this patient, but there is a challenge how to use this modern technology, particularly how we integrate all the information and how we select a specific treatment for individual patient, not based only on opportunistic availability of treatment or a mutation that just we recognize. I want to stop here and take any question. Thank you.